Hello. Welcome to Medical Gazette. Today we are going to talk about epidural haematoma. I will show pictures to the end of the video and explain them. Let's start. So what is it, an epidural haematoma? Definition. Presence of blood in the space between the inner palate of the diplo and the dura. Epidemiologic data. Age, usually 20 to 40 years, rarely under 2 years, and over 60 years. Sex, most often in males. Frequency. 2% in craniocerebral injuries. Usual localization in the cou area. Over 95% unilaterally. Location 90 to 95% hypersenoids, usually temporarily. The size varies. Rapid increase in size over time. Clinical features. Bright break. The symptomatology depends on the size of the haematoma and the accompanying findings. Radiological findings. Generally. Becambent or lenticular blood collection in the area of injury. It does not pass through the seams, unless there is a seam dimension or a fracture in the seam area. It can be extended beyond the adhesion of the cerebellacine and sickle. It pushes and displaces the adjacent subarachnoid spaces and cerebral parenchyma. Usually, 90%, is of arterial origin due to staining of the median meningeal artery from the fracture. Venous origin is located near the venous sinuses when they cross the line of fracture. In one half of the cases coexist fracture, subdural haematoma on the opposite side, cerebral contusions, echolespism. So what do we see now in imaging methods? In radiography we see cranial fracture. In computed tomography we see, in the acute phase, usually hyperpigmentation with pressure in the adjacent parenchyma. The presence of hypocercal areas in the bloodstream indicates active bleeding. Air presence indicates concurrent fracture in the lithoid and mastoid or frontal sinuses. In chronic hematomas, and after IV administration of contrast media observation and peripheral enrichment. In magnetic resonance. Imaging varies with age. Acute, T1 equal intensity signal, T2 low signal. Subacute, T1 high signal, T2 low. Chronic, T1 high or equal intensity signal, T2 high. Differential diagnosis. Subdural haematoma. Neoplasm-like, meningioma and metastasis. Extramedullary hemipoiesis. Prognosis and treatment. Immediate surgical drainage. Mortality of about 5%, greater in bilateral, about 20%. Now we will see some pictures and explain them. In this picture we see A. Necrotic preparation. B. Hyperpigmentation of the haematoma with a biconvex configuration, limited to the height of the coronary suture. C. Bone fracture in the course of the middle meningeal artery. In this images we see A. 3D imaging. Ocular bone fracture that intersecting with the lamellar seam causes a dimension of sagittal seam. B. Accompanying hematoma from damage of the venous sinuses in the area of the herophyllous torcula. In the last images we see A. Temporal bone fracture with extension to the roof of the lithoid stone. B. In the presence of a small epidural haematoma, in conjunction with air bubbles, a finding indicative of the communication of the air cavities of the lithoid with the intracranium. Thank you for watching. Please subscribe and like the video to help us expand. Drop us a comment about your thoughts. This is for now. See you in the next video.